Hello, my name is Tracy Karp. I'm a Neonatal Nurse Practitioner at Intermountain Primary Children's Hospital in Salt Lake City, and here as part of the Academy of Neonatal Nurses annual meeting in Nashville. It is a pleasure to present to you this Minute CE about the challenges of funny movements in the well baby environment. Basically, we're going to talk about seizures. So we have a little case to talk about. It's 3 o'clock in the morning. You're the frontline care provider. You're in to see little baby Lightning, who is a late preterm infant of a diabetic mother, and his mother notices something funny about his movements. Initially, as you watch the baby, everything seems fine. Just as you're ready to leave the room, the mom cries out, "He's doing it again." You turn around and you notice that the baby is rhythmically moving his arm back and forth, and he is about to turn blue right before your eyes and become limp. You stop and decide what to do. So, what do you do to keep the baby safe? Well, we're going to talk about seizures. They're the most common and distinct neonatal sign occurring in the neonatal period, may represent significant CNS disease, may represent significant systemic or treatable insults, may be frank and overt, or even subtle and quiet and difficult to tell. It can be a medical emergency, can signal life-threatening illnesses or disorders, and if prolonged, the seizures themselves may reduce brain energy stores and cause subsequent cellular injury. They may also interfere with other life-threatening functions, such as breathing. Now, it can be a medical emergency, as I said before, and we want to go ahead and look forward to some of the primary etiologies. That would include brain malformation, genetics, metabolic causes that we'll discuss. Secondarily, it may be a result of other insults that are acquired, such as hypoxic ischemic encephalopathy, intracranial bleeding, infection, or metabolic disorders such as hypoglycemia or hypocalcemia. In addition, it may be related to iatrogenic problems such as drug exposures or drug withdrawal. Exposures could include inadvertent administration of substances that might facilitate seizures such as lidocaine. Drug withdrawal, most commonly in 2016, might relate to the withdrawal of opioids in a situation of opioid dependence. There might also be embolic or trauma causes. And finally, there may be idiopathic causes such as unknown family or familial causes such as epilepsy or things as fifth-day fits. Now, one of the things that the babies present with are various types of abnormal movements, and I'll only speak briefly to a few of them here. They include movements of the arm that might be in rapid succession that relate to myoclonus. There might be consistent movement of the extremities, especially the lower legs, that might be considered bicycling. Consistent movement of the arms, either in rhythmic movements or being drawn across the chest, that might be considered like drum beating. There may be, on the other hand, after these movements, loss of tone and limpness, and finally, rarely, there might be general body tonic-clonic movements, but these are quite rare in the newborn. Sometimes these abnormal movements come in clusters and may relate to various other types of extremity extension or flexion. So what do we do when these situations occur? The first thing is to facilitate the patient's safety. We want to look for conditions that we can treat, and those include hypoxia and situations where there might be low cardiac output. And then we would go ahead and initiate therapy for those, such as oxygen therapy, support of the cardiovascular system. The other thing that's very important to screen for are various types of body or brain infections, specifically meningitis or generalized sepsis. The baby needs to be screened for various types of biochemical abnormalities, including hypoglycemia and hypocalcemia especially, but there are other abnormalities that should be looked for, including inborn errors of metabolism that might be screened for by measuring a serum ammonia. And finally, then we want to potentially dig deeper through brain imaging. In the modern era, we're most talking about doing MRI studies, but emergently, ultrasound, and even potentially CT can be utilized. And finally, for diagnostic work, EEG with video, and in some circumstances, long-term monitoring with amplified EEG may be needed. What are the treatment? Well, as I spoke before, it's supportive vital function, including oxygenation and ventilation, providing the necessary substrate, or removing an offending substrate, such as in infants who have seizures from inborn errors of metabolism. And then we want to ensure that we provide the necessary antibiotics or antivirals. And lastly, not as a reflex, to provide anticonvulsant or antiepileptic drugs that may either reduce or stop the seizure activity. The number one drug currently in use remains phenobarbital, although other drugs such as lorazepam and midazolam can be utilized. Nursing care should be focused on protecting the patient from harm, identifying and reporting the various events, including detailed observation, which might even include video recording, and supporting the diagnostic workup. And finally, relating to outcome, it all depends upon the underlying neurological disorder. In general, it is not, I would say, as bleak as people suspect. In some cases, 50% of those babies who suffer various types of seizures may still have a normal outcome. Those seizures that come from various types of intracranial hemorrhage have varying degrees of neurological disability. Of course, the most concerning ones are those that occur from developmental defects and specific brain migration abnormalities. Thank you very much for your time and attention, and have a good day.